Hello everyone, I'm Annabelle from SIUK and I just want to thank you for joining us today for our webinar on wound management in systemic sclerosis. Today we're joined by Dr. Begonya, who is a research expert on digital ulcers. So she will be giving a half an hour-ish presentation and then we'll be taking questions in the Q&A format. So you'll be able to see at the bottom of the screen, there is a little Q&A button. So feel free to just put your questions in there and then we'll get round to those at the end. However, please be aware that this webinar is being recorded and will be placed on YouTube afterwards. So if you have any too personal questions that you don't want to share, just keep that in mind. However, you can also ask questions anonymously. And also please be aware that we won't be able to answer questions that are too personal to your own diagnosis. So without any further ado, let me introduce our speaker for today. So Dr. Begonya is a NHS clinical researcher on connective tissue disorders. So she has recently set up her own clinic on ulcers with another researcher and splits her time 50-50 between the research and the clinic. And so we want to thank you all for joining us and we hope that you find this session really informative. So without any further ado, please do take it away.
Thank you so much for inviting me to give this talk. It's kind of really good thing to do because anything that I can inform the patients is always beneficial for the patients, but also very beneficial for the clinicians because we are preparing you a little bit more to understand what the disease is and how it interacts with the ulcers and so on. So it always helps us and you. So I'm very pleased that SIUK gave me this opportunity. So as Annabelle explained already about who I am and what I do, I'm just going to go ahead with it. So basically today we are going to be looking at ulcers and talking about ulcers in systemic sclerosis. We're going to look at the understanding of the causes that produces the ulcers, also identifying the skin lesions and ulcerations. So you are familiar with those things to look for. And then what treatments do we use? The treatments, I will be focusing on local treatment, not so much systemic. However, I will mention a systemic treatment for specific for ulcers in the scleroderma as well, just very briefly. And then we'll look into the red flags, and then we're going to go into the self-help and how can you prevent and manage skin ulcerations. So just a very quick overview. So skin ulcers can occur in different areas of the body, but the most common ones are on the digits. And that's why mainly all the literature and all the research are very focused into digital ulcers. So we cannot translate to other ulcers with certain things. We can utilize same kind of treatments, but it's mainly specific for digital ulcers, what is available on the literature. Digital ulcers tend to happen mainly on the fingers. Around 50% of patients develop digital ulcers on the fingers, and around on the toes also okay, but there is a variation. It's been reported between 1.5 to 26. So it's less common on the toes, but it's still happening. And around 3/4 of the patients will develop a DU on the first 5 years of the disease or the diagnosis. Ulcers tend to reoccur in around 66% of the patients, but it doesn't mean that they have to. Now with Bosentan, it has improved quite a lot, to be honest, the reoccurrence of it. It doesn't happen as much. And then what we need to bear in mind is that the ulcers are caused by multiple factors, and those factors are related to the disease. And as we're going to go through, you're going to see. So basically, you know very well about what Raynaud's is. You all probably experience it, or a majority of you have experienced it. And I don't need to go too much into detail, but you know it's a vasospastic condition. So basically it's a vasoconstriction, and it normally is when you react or you're exposed to changing temperatures, particularly the cold, or you feel anxious. That would also kind of trigger the Raynaud's happening. It tends to happen around 23 minutes average. It's been reported, but it can last hours for some of the patients. And it tends to be both hands at the same time. If it only happens in one hand, then there could be other pathology and it's not related to Raynaud's as such, as what we will say the primary Raynaud's. Basically, it could be because there is like nerve entrapment and so on. So that you also need to check if it only affected one hand. Right, so how the Raynaud's presents, you all know it, there is a change in color. You have the white, and then it goes to the blue, and then it goes to reperfusion, which is the red. And as it goes through these processes, when you have the white, it's because the blood is not reaching that area. When it gets into the cyanotic, the blood is there, but there's no oxygenation, there is no oxygen on the area. And the red is normally when the blood just rushes back into the fingers, and it creates the sensation of feeling more like a pain. So the beginning to start with tingling, numbness on the second stage, and then you go into the pain. And this pain can persist. So the pain is straight away after the Raynaud's, it ameliorates, but you can be left after repetitive Raynaud's attacks, you can be left with what is called allodynia, which is very sensitive. Your fingertips becomes very sensitive. It's kind of hard to pick up coins, and it all feels like sensations that should not feel pain. It feels a little bit painful on the tip of the fingers. Now, another contributor towards the ulcers, and this is one of the main contributors to the ulcers, is the vascular problems or the small blood vessel damage that is happening related to scleroderma. And this is kind of like the main pathology that scleroderma has, the microvasculopathy of it. So what you find with this, as you can see here, this is the fingertip, and is an example. So basically on the nail bed, and then if you, let's say, we extract a little capillary or vessel from that area, and this would be what it should be a normal vessel. So you have plenty of space there to go through with the blood. And then what happens with the scleroderma is we start to have like extra growth because of the fibrosis and fibroblast on the area and muscle cells. It starts to grow that area, and the lumen, the circle, the cavity where the blood goes, basically ends up being really, really small and obliterated. And it means it closes down, and then is when we see the ulceration. So at this stage, you're still having blood flow. This stage is later stage. The capillary or the small vessel is more damaged. And this causes that a little thrombus on the area or a little clot will stop the blood flow going, and you're not reaching, the tissue on the area is not reaching, doesn't have as much blood flow, and then it breaks down because there is no oxygen and there is no nutrients for the tissue. So as you can see, once we have a damage, because caused by the vascular not having enough blood flow and there is not enough oxygen, the body has a way of repairing itself. So it automatically tries to create new little capillaries or new little vessels to kind of get the blood going into that area again and not to lose the tissue. But unfortunately, in scleroderma, this process of repairing process, it also is impaired. So we not only have the problem that the blood flow is stopped, it's also once it stops going there and the capillary is damaged, which are these little capillaries here, when they are damaged, then you end up with areas where there is no capillaries because we don't have the new formation of capillaries occurring. And therefore you have this very characteristic ulceration. Imagine this is now for capillaroscopy. I'm sure most of you have had them done. And then they look at the capillaries on the area, and areas where are called avascular, there is no capillaries, then you tend to have the breaking down of the skin because there is no oxygen, there is no nutrients, and the skin just starts to break down and the tissue in that area. These are typical ulcers related to the small vessel disease, as you can see it. These ones are mainly involved also with the fibrosis, but the ones on the fingertips and toes, you tend to see them more. So here is a nice way from MRI, and as you can see, this is a healthy control. When we can see the ramifications at the end of the capillaries, while when we compare it to a scleroderma patient, you see there is already the digital arteries start not being there, being damaged, so you're not getting as much blood flow. And this is a very clear example when we put the finger of the patient here on the MRI, and then we'll see here, you can see there is no blood flow here. We already lost the tip of the finger, and eventually this finger was amputated as well. And you can see there is like little pre-ulcerative areas here. There is those blotches on the skin, and this kind of a little bit more of hyperkeratotic pitting scars, but all of those areas tend to break down. And if you look into this picture, it's right on the area where there is not much blood flow going either. So it's quite nice to see how it happened, what happens inside, and how it shows outside. Now, we also have large blood vessel damage, and it's not as common as the small vessel damage in scleroderma. It's not common, but it can be present. So we have like an early atherosclerosis. So basically, the arteries starts to kind of get like on the wall, like a little bit more cells and fat that's traveling around the blood flow and so on. And it creates like hardening of the arteries, and also creates a reduction in the lumen. So you are not getting as much blood flow. So if you can imagine you don't have as much blood flow through the big arteries coming down, and then you don't have much blood flow going onto the little ones either, and you have the blockage coming all the way up, then we tend to see these larger lesions, this larger breaking down of the skin. They are larger patches, and they tend to appear as more gangrene-like, while the other ones, they tend to appear more as a little areas affected, but not so much gangrene. When we have a blockage on the artery, larger arteries, you tend to see these big patches. And there is a predictor. So when we have occlusions on the arteries, there's a predictor that they will develop digital ulcers. But as I said, it's not as common as the previous one. Now, we can also have blood vessel inflammation, which is called vasculitis. That's not a common one in scleroderma, but in some patients do present. And it's normally small vessel vasculitis. So you will see presentations like little dots like this. You don't see the larger ones. This is more small, and sometimes it can be even around the ulceration. So normally with these little ones, you might not see that they produce big ulcers like this one, but combined with all the other issues with the skin and the other vascular problems, and in leg ulcers, obviously the venous problems and so on, then they can make it worse for the healing. So we need to control the vasculitis if it's present. But as I say, they will always present like more little dots or areas like that in patches. So those are more related to vasculitis. Now, things that are very important to see is how to detect ulcers or areas that might be pre-ulcerative, as is the beginning before the ulcer occurs. And this is where you need to look for the skin and different changes. You will notice, because there might be areas where you'll start seeing very clear whitening, where you're not getting blood flow, and it's more constant and it's persistent. And you also can see that there is like more dusky color, more bluish color. That's the blood flow is not going through. I'm sure some of you have experienced this. And then you can see that there is like areas as well like this, as I previously showed with vasculitis, where there is more targeted areas, have not broken down, but the color has changed and is not quite right. And this will come always, or majority of times, will come with pain. Pain will probably be constant, and it will be present and persistent. You will also feel like the hands are much more colder, and even tingling and numbness at the beginning. And as it progresses, you will see that it worsens in color. This is more necrotic. This is micro and macrovascular disease involved, but probably inflammatory as well in this case. But you can see it progresses, and it might progress slowly over the weeks, but within 2 to 3 weeks, you probably see this. You go from there to a proper open ulcer at the end of it, and in some patients even earlier than that. But any changes at this stage, please go straight away to see your consultant or other clinicians that are looking after you, because we can intervene with the right medication at that time, and we can save quite a lot of the fingers. Now, skin fibrosis. Skin fibrosis, you all know as well, you're very familiar, is a hallmark of the scleroderma, and it also contributes to the ulcers, and it contributes to the ulcers in regards of what we're going to discuss now. So basically how the skin, it changes through the disease. So it normally has a stage where it's like more like edema, like more swollen and puffy, and then it goes to the fibrosis stage, and then it becomes to the atrophic stage, most of this. So what happens when we get subfibrous skin is the skin loses its biomechanical properties. Basically, it loses its strength in the aspect that, because it's become very tethered, it doesn't have as much flexibility, so it doesn't conform as good for pressure or stress or friction, anything like that. It will break the skin quicker. But also you need to be aware that we also have an underlying disease, which is the vascular problem. So if you don't have enough blood flow, and then this skin is already compromised because it does not have enough blood flow, and now it cannot move as well, and you're pressing more, there is more friction because it's very tense, like you can see in this hand here, where it's also blanching, because the fibrosis is so large that it's blanching, is making the blood constriction in there, because it can't flow as much. Those areas are more prone to have the ulcers, and they are more in danger to break down. So those are the reasons why the skin contributes as well onto the ulceration formation. From the skin, we can see that it also develops excessive hyperkeratosis, which is callus-like format, which is called pitting scars. And it develops in any area where you have friction, or you kind of hold cup of teas, or you just use your cutlery. The areas where they get more friction and so on, they tend to get more the pitting scars, and it's the callus. And the problem with the callus is when it's there, that makes it even harder for the skin to have the flexibility, and it creates a focal point of pressure, and sometimes it can develop into ulcerations. So not necessarily pitting scars doesn't always develop as ulceration, but because we have the blood flow and compromise and so on, and the skin's compromised, and the increased pressure in that specific point, it can break down. Now, skin fissures, they are not ulcers, but I thought it's important to know, because if left untreated, they end up with, you can also end up with having infections and so on, and it still is open, it's still being like a wound, and it could lead to larger wounds. But it's important for you to know that is mainly you need to hydrate the skin constantly. And I know dry skin in scleroderma is an issue, but I mean, like constant hydration, it would be the best thing to do. So mechanical stress, this is another contribution. So if any deformities on the feet or any pressure points on the areas, because due to the fibrosis, we also lose the plantar fat pad, which is why it gives us more cushioning on the ball of the feet. So that's why it feels sometimes that you walk in puddles. So in those cases, you will have more pressure from the bones onto the skin when it touches the ground or the shoe. So you can see areas where the arching here has been collapsed, where the navicular joint here has collapsed, then those areas become a focal point of pressure. So that repetitive pressure every time walking, the skin is already compromised for other factors. Now you add this, it will end up breaking down into ulcerations. And also on the ball of the feet, very common, we tend to see where the metatarsals are going through the bone on the ball of the feet, are kind of very on the surface, and repetitive trauma from walking ends up breaking it down. Now, one of the last factors is calcinosis. So calcinosis, it can occur in anywhere in the body. It tends to be more in areas that get pressure and that they get trauma or skin infection. Those is where you tend to see it. You also see it very commonly in the hands, obviously. And they are the position of calcium-containing crystals, and it is within the tissue. And the thing is, you can have that, but most of the patients ask, oh, is it because I'm being osteoporotic and the calcium is being absorbed? And it's nothing to do with that. You will come up with normal calcium and phosphate serum levels. It's just that it's an abnormality, and we're still not understanding, and there is research going on to understand a little bit more about it. So this is another cause of calcium. And this is when it's like toothpaste or like material, like it looks like our paste. It presents on the microscope like that. And when it's a stone that is formed like a stone, it presents like this. Now, treatment. So basically, when we treat ulcers, we don't just treat the ulcer, we treat the whole patient. And it's so important because we see it. If the disease is not going well, we need to see the disease activity. When the disease is not going well, when the patient is experiencing a flare, I'll see them in clinic just shortly with ulcers. That is so related. And then we need to also treat it with the systemic treatment with the drugs, either to control the disease, but also to improve the blood flow. And then you also have to be very important is the psychological factors. So all the psychosocial factors will have an impact. Stress, anxiety, all those things will have a massive impact on how the patient heals. And in this case, we're going to focus mainly onto the local wound care, but I will touch the systemic treatment first. So you will probably be quite familiar with the drugs that you are using. So normally they will start you with calcium channel blockers to manage the Raynaud's and the blood flow and so on. And then it will progress onto, if we're seeing that there is ulcerations occurring or is not improving, then you'll go into the given sildenafil. And then it goes into iloprost more regularly for those who have more ulcers more frequently, maybe to prevent it as well. But iloprost is not so much to prevent, but to heal ulcers when they are present. But some patients also find it beneficial for the Raynaud's. So we tend to combine it in some of them, and some of them we use it when we really need it, when an ulcer is present and is no healing, then we'll give the iloprost. And then you also give bosentan. And bosentan now is gone off patent, so it's much more cheaper. So it can be is prescribed more frequently, obviously. Bosentan, what it does, the theory behind the bosentan is basically that it doesn't actually heal the ulcer, but it prevents further ulcers. So it helps them. So if you were to have 10 ulcers, you have only 5. If you have to have 2, you only have 1. So that's the theory. But at the same time, we all the clinicians believe that it also has an effect on the blood flow and the healing of it in a way, even though in research has not been shown. Now, the wound care. So we're looking at mainly when an ulcer presents, we try to clean the wound bed, and the wound bed is basically the surface of the ulcer, and we want to remove any debris, any biofilms, which are microbes. Is a film on top of the ulcers that having very long standing, and it's just full of microbes, and it's not letting the ulcer heal. It's interfering with this, and it's also interfering with the infection. Any slough, any pus we need to release, and so on. So we basically want to clean the wound. We make it so we can expose the wound bed so the treatment can be more focused. So we start by normally cleaning just with saline water or any surface like Protosan and so on, which has an antiseptic, or we go a deeper cleaning with debridement, and we tend to use debridement quite a lot, particularly in leads. However, there is no full evidence for it, so I will explain a little bit more about this later. So when we look at debridement, what it allows us is to be able to clean it sooner. You can debride wounds in different ways by giving a specific dressing, but one of the fastest way is to do it with a blade. And this is like a pitting scar. So basically this was an ulcer produced by pitting scar. It's trying to heal. We don't know if it's healed or it's not healed. As soon as we remove, we can see epithelializing tissue, healthy tissue healing really well. So that's a good also to see what's happening underneath on the wound bed for us to decide on the treatment. Then we have also ulcers that are from the small vessels, as we were saying before. And when we open it, we have the full surface now exposed, the wound bed. So now the medication we put or the dressing we put is acting on those cells and is promoting the healing better. Otherwise, it does not penetrate. Then we also have those more produced by the large vessels being blocked. And once we remove all the dead tissue, basically this dead tissue, and all it does is a ground for growing bacteria. And what we want is to clean all that up. And then we have a wound bed with a bit of a slough and fibrin, but we can start acting upon it with the specific dressing, and it will work faster. And then when we go with calcium deposit, as soon as you remove the calcium deposit, then you find already a relief. They tend to be very clear wound beds with calcium deposits, and once you remove it, they tend to heal quite quickly. Now, debridement is also used to remove the liquid trapped in the wound that is creating lots of pain. So this happened within a week from that stage to this stage where it was extremely painful. It was 10 out of 10 of pain. We debride it as soon as we release the pus and we release the exudate of the liquid. The patient instantly, there and then, it came from 10 down to 6. The pain is a relief because the pressure is not there on the tissue anymore. The wound bed, it looks really nice. It's very healthy. Has blood flow, and hopefully we'll be able to heal that very quickly. And the same here. You can see when it presents with things like that, those blanching areas surrounding. As soon as you release, underneath there's probably pus. And if you leave the pus trapped in there that cannot exit, it creates a bigger wound inside, and it tracks inside through little sinuses. So we need to make sure that those is released. So if you suspect of any like this, go straight away to have it lancet and the pus to come out. A very important thing on ulcer treatment is the moist balance. I know some of the consultants, some of the clinicians might say, just leave it open to the air to dry. That's a myth. It doesn't. No, don't leave it open to the air. Don't leave it to dry. We want the opposite. So what we want is moist. If you have moist, the cells, the epithelial cells, are able to come across and start building the new tissue. Now, when a scab happens, when it becomes dry, the area at the bottom becomes dry, the wound bed here, the area at the bottom becomes dry, the cells cannot come across because it's all dry, it's a plug. So then they have to go all the way down and start growing their way to come up. And it takes much more longer on the healing. It also gets worse scarring, so you have more scarring. So that's why we tend to remove the scabs if present and hydrate it, so for the scab not to form in the first place as much. And then this is a very clean, nice wound bed who's been moist controlled as well. And you have a very granulation tissue and very healthy. The moist has to be moist, but it has not to be excess moist. So that has to be always regulated. And I'll touch a little bit about this later on. So skin, we need to prevent the skin. The skin, we need to protect it. So a very important thing from the beginning of the scleroderma, as soon as you start developing skin involvement, is to hydrate the skin a lot and do exercises, stretching exercises, so the skin gets as maximum flexibility as it can, and we don't just let it become really flexure contractures. So that's very important. Hydrate. Vitamin E. There was a small pilot suggesting that vitamin E used to help the ulcers in healing. So for that reason, I use vitamin E creams, but there is no more research behind it. So that's the reasoning behind it. You can use any other cream, whatever cream that you feel that is sinking in, that is making your skin better, use it. Better cream than nothing. Even normal Vaseline, you'll find that it will improve. And then make sure that you can also use cream with urea if you have a big build-up of callus or hyperkeratosis that tends to break down the hyperkeratosis. And just occlude it with gloves, with cotton gloves after you put the cream. If you occlude it, you'll find that that will improve much better, because it will reabsorb the cream much better. You can also use like silicone sheets and so on, but just the routine of cream with gloves occlusion, you'll do well. Now, what we were saying about how the moist has to be controlled. If moist is too much because the wound is producing too much moist, just so be it, because it's infected or inflamed. So then you have to control it, because when the wound becomes macerated, the lesion around it becomes all macerated. That means that the skin will start breaking down around it. So we need to control. We want moist, but we don't want excess moist. So it has to be controlled. We tend to protect it with like barrier films, like Cavilon, for example, or some emollients around it, and then it protects the skin that is around the ulcer. So we know the exudate can also damage and create inflammation. So we need to regulate that with the specific dressings and so on. Not only control the fluid coming out, but also control the type of fluid. If it's infected, if it's exudate from infection and so on, then we'll create more inflammation and we need to treat it. And also sometimes we can also treat it with topical steroid, but we have to be careful that it's not infected at the same time, because steroid will reduce the inflammation and it will stop fighting the bacteria that is in there. So it has to be steroids combined with antibacterial properties or antimicrobial properties or antibiotics. Now, treatment of fissures is very similar to before. You just need to make sure that you cream your feet as much as you can. But one of the things that we do is we tend to debride the fissures, like the sides of it, the hard skin around it, or file it. Don't file it very frequently, otherwise you create more hyperkeratosis, more calluses. So, but another thing that you can do is very good, and this is why I put the pictures, Gelonet or Bactigras dressings. They are paraffin dressings. You put it in there, you occlude it with a secondary dressing, which is a dry dressing, and some tape, you put it in there, and then because you leave it there for a few days, it starts to nourish the skin, and it works very, very well for the fissures. So be it in the hands or the heels. And again, make sure you moist you feed it 2-3 times a day. It doesn't matter, as much as you can put it, the better. Make sure you don't get excess, so you don't macerate it or make it soggy. But you can do it after you had a bath or shower, is better, or you soak your feet, because the skin is already absorbed some moist, and now you are sealing it by putting the cream on it. And then if you cover it with cotton gloves or gloves with gels inside, which actually or gloves or socks with gel inside, it retains more the moist. So those things are good to do with the skin fissures. Now, treatment about calcium deposits. The most important thing, as before, is extracting the calcium. So if they are very superficial, we take it out with a blade, we protect the skin, and we occlude them with a little, if there is leftover calcium, we occlude it with a little bit of an occlusive dressing, and then we put a little bit of gel, aqueous-based gel, to break down whatever is left inside. But we need to be careful on protecting the perilesional skin so it doesn't get macerated. If it's a large area, if it's a localized area, but we cannot reach because it's not open yet, it can be done through laser. Laser facilitates the cut on the skin, and then they remove it because it breaks down a little bit the colors. And if it's large plaques like here on the elbow, what we do is we do surgical excision. However, it's very hard to remove all the colors. All the calcium deposits. So that's for you to discuss with your surgeon and decide what they can do for you. And as I was saying before, the deformity of feet or feet, the areas that are having a low pressure, that can be controlled by giving the right insoles or making insoles appropriate for the foot shape. And also on the acute phases where there is an ulcer and we want to heal it, then we can use like offloading boots or offloading shoes. Red flags and complications. This is just so you know, so you're familiar about infections. I'm sure you've seen it, but sometimes you don't know, well, is it infected, is it inflamed, and it's hard to decide. So normally ulcers are colonized. You will see that there is some normal flora or microbes that are present on the skin, but when that gets, the microbes are growing a bit too much, more than they should, and then it becomes an imbalance, then is when infection starts to happen. And then is where you like colonize, like critically colonize. So you will look something like that, it's critically colonized. There is probably an infection there, is present, but we can target it by using the right dressing and probably maybe topical antibiotics. But you can monitor it and you can try it like that. If it's worsening, if it's starting to get more swollen, more pain, the pain and the swollen, but particularly the pain is a very big indicator in scleroderma, unless you have neuropathy, which is not common. But if you have any changes like that, the redness starts getting bigger and so on, you start seeing that the infection is just starting to get bigger, then you need to start giving antibiotics. We'll normally take a swab. We start with a broad spectrum antibiotics, which means it covers a lot of bugs. And then we go into modification of it once we have the results from the swab. And if you have infection that is spreading, you can see it's going past this, it's going bigger, larger every time, you probably have to be admitted with IV antibiotics and iloprost. We combine it with iloprost because then we open up the arteries so the antibiotics can reach into the area and also helps the healing. When things become even more complicated, the bone can get affected, particularly on the areas with the fingers, because the bone is very superficial. So when the skin opens, it tends to see the bone quite quickly, because there's not much tissue in there. So then when it reaches the bone, we normally tend to confirm it by X-ray or MRI. Some microbiologists always want like a biopsy of the bone, a fragment of the bone, but we don't like to do that because we are being very intrusive. So we stick to the imaging, and the treatment for osteomyelitis, again, is IV antibiotic, iloprost, is for a longer period, and the closer monitoring as well for this one. And then continue afterwards with oral antibiotics for 6 weeks. So it takes a bit. You can combine it with hyperbaric oxygen therapy, but that is quite time consuming, and some patients, and it's hard that not every way is available, but that would certainly help with the absorption of the killing of the anaerobic bacteria particularly. And dressings, obviously, always dress it, keep it dressed, and follow the instructions. Other complications, ischemia, as we said before, you normally go for when you have ischemia, you have to have the systemic drugs, but conservatively, we can manage for the Raynaud's, try to keep your hands warm. And then there are other creams that also vasodilate. So we tend to use that to improve the area. But those ones have to be monitored, because you cannot take them or have them if you are having certain medication orally, like sildenafil and so on. Always check for dressing. So we'll use if inflammation is related to the infection. If you have more inflammation, then we'll need to get dressings that are specific, not only that is antiseptic, but also an anti-inflammatory, such as honey. It has the two properties, which is very good. And then we might also look like to give topical steroid with some antimicrobial properties. Then you can also get inflammation related to the calcium. And this sometimes get confused by a lot of GPs or people who are not used to thinking that because it's inflamed the calcium because it wants to come out, they give a lot of antibiotics. So please confirm it or take a swab if you suspect that it might be infected, that there is something in there. But calcium deposits will probably flare because it wants to come out, not necessarily because you have an infection. So if you even doubt, always ask your clinician, but particularly the specialist one. And then you can get irritation due to the constant use of dressings as well. The skin can irritate, so you need to try to avoid the product and maybe just alternate where the dressing goes. So make it a bit larger or smaller so it doesn't always touch the sticky bit of the dressing on the skin. That way you will avoid any irritants to the skin area. And pain. Pain is also one of the big issues and complications with this. It normally comes either with ischemia, the infection, or you could also have neuropathic pain, particularly on the fingertips, as we were saying before, related to the Raynaud's attacks. That can give you that pain in the fingers and so on. That can be treated with the neuropathic pain, can be treated with the drugs. Obviously, all the other pains as well, but you will use different drugs depending which type of pain you have. So with neuropathic pain, pregabalin tends to work quite well. So, and then obviously you can have the pain related after we just done all the work and debride your ulcer, and then for that we can give you like cream, like lidocaine cream, like anesthesia cream, and it settles down. And we talked about all the local treatment and a little bit of the systemic. What we know is what we use for local treatment is what is available there, used from other wounds and other diseases developed with wounds. Some of it is specific for scleroderma out of experience and knowing how they work, the ulcers, and some is for little projects that have been published, but we don't have substantial research on this area. We don't have enough research with larger numbers to decide which treatment would be best. And at the current moment here in Leeds, I'm running a study which is looking at basically debridement, as we were saying, with the blade, removal of all the debris and everything, and compared to just the dressing on its own. And we want to see if you do debridement and the dressing, if that improves compared to when we give the dressing. And at the moment we are recruiting, so if anybody is interested later on, I can give the telephone number. But we are doing it here in Leeds and also in Royal Free London. But you can come from any part in the country. As long as you're willing to come to travel, we can pay for travel expenses. That's the only thing. So we will look at all these things. So self-help, what can you do? There's a lot of things you can do. Sometimes it feels like helpless, but no, there's a lot of things that you can do. First of all, make sure you take the medication as prescribed by the consultant. If you don't understand what medication is what for, ask, because I can see in clinic lots of patients that sometimes, because you have so many medication and it's all so complex that sometimes you don't know exactly what are you taking for. Also, make sure that you review your medications. As soon as they give you one medication extra, check with the consultant, do I need to carry on using this other medication, or this one will substitute the previous one? Because we don't want to have more medications than we actually need. And they can start also tweaking things like, okay, we'll take you this one off and we'll put you into here and see how that one goes. And if not, we'll introduce the other one that you had before again. But always, always check your medications. Check it with your consultant, with a non-medical prescriber, and one of them, I just monitor a small group of it, but not the larger medication group. And then just check it with your pharmacist. They're there to help you out. And make sure that you keep it dressed, that the ulcer is dressed until the end, until it's completely healed. Because that way, we're avoiding any infection, anything that can go in one is an opening. Change the dressings every 2 to 3 days. Sometimes the dressings say you can leave it on for 5 days. And yes, that's true. But every 2 to 3 days, the reason is because I like you to check how the ulcer is progressing. Is it getting worse? Is it getting better? Also, you get a chance to clean the ulcer and then you redress it. If the dressing becomes wet or dirty or saturated with a lot of liquid coming out of it, you need to change it immediately. And by dirty, I don't mean a little bit dirty on the outside. I mean like dirty, you mean pottering around in the garden or something like that. And it gets really dirty, that needs to be changed immediately. And the reason is because otherwise the dressing gets lost its properties and you have more risk of getting infected and so on. And also follow the instructions as recommended by your clinician, as different dressings will have to be in place for different times. You can take photos of the ulcer as it progresses as well, how it's healing and so on, because then you can show the clinician, or when something goes wrong, you can show the clinician and then they can see it. So that's very good and helpful. And any unusual changes that you see on the skin, contact us straight away. If we catch it early, we can do much more for you than if we catch it late, and the complications are reduced. And I cannot emphasize this enough. I know it's really hard. We all tell you avoid and minimize stress and anxiety, but I can see lots of patients, the disease is controlled, everything is perfect. They have bad news in the family, something has happened, they are more stressed at work, and ulcers happen. Because stress has an impact, particularly anxiety, if you're worried about what's going to happen to you, things like that. There is a lot of help out there with psychology that you can go. And it doesn't mean that you have any psychological problem. It just means that it will be better for you. You'll know how to manage better. It'll give you coping mechanisms, or even simple things like meditation, or having some time to go and do something that you really enjoy, that calms you. Things like that will manage the stress and anxiety, and it's very important. we'll reach the end. So the summary is there is many different types of ulcers, as we can see. The main causes of the ulcers is the impaired blood flow, the skin fibrosis, the calcinosis, and obviously mechanical stress is an added factor to all of those. If you have it, then it gets worse. The treatment always depends on the characteristics of the ulcer and also the patient health. It depends if it's tailored to the patient as well. And we need more research and more research studies to know more and understand better what treatments will work better for you. And also you can do things to prevent and heal ulcers. And it's very important that you are proactive and that you look after yourself. That is extremely important. So acknowledgement to all the patients that come to our clinics. They are wonderful, and they help us as well to understand better the disease, but also they give us tips that we can pass on to other patients. I'd like to acknowledge particularly Professor Delgado, but also Lorraine Green, because she works alongside me in the clinic, and she does a lot of work with me, and she's also very focused researching into the calcinosis side of it, which is much needed. And thank you very much. This is the telephone number for the study. But also, if you are concerned, you don't know who to contact, or you need to see somebody, I'm quite happy to arrange it for you to be seen into our clinics. You just give me a call and we will arrange it with your consultant, wherever site in the country you are. I had people coming from Northampton, I have people coming from down south. So anything, we can start you and fit you into our clinics, and then we can arrange how to do that. So any questions, I'm happy to take.
Thank you very much for that. That was very, very informative. I feel like I've really learned a lot. I'm sure everyone else found it really useful too. So yes, if you have any questions, please just put them in the chat and we will go through them. Oh, someone's also just said yes, that was also very helpful. So just thank you for that. Shelley has asked, can dressings and wound care be available on prescription?
Yes, they can. Not all of them, and it all depends on your GPs. But yes, we tend to do, I tend to give maybe sometimes if I give a tube of honey, if I use it for the patient, I give that one to the patient to take home because it lasts for 3 or 4 months. So it lasts quite a long time. But I always ask for them to ask for the repeat prescription of dressings in for the GP. But it depends on GPs. Some of them are very happy to prescribe everything. Some others might be more tight with the money and the budget. But yes, it can be.
Yeah, I get that. Liz has asked if you could explain a bit more in detail about how alloprost works, so the benefits and the side effects, just a quick, more detailed summary, I guess.
So just a really quickly one. So alloprost basically is a vasodilator. So when we give you the alloprost through the infusion, then it opens up all the vessels meaning where the blood flow goes, the tubes that the blood flow goes through. So it opens up and then it can reach to larger areas. So all those vessels that we were seeing originally, that was very kind of like small and constrict, and you did not have enough blood flow. Those ones will open up whatever they can, because once they are damaged, they cannot fully open either. But whatever we can, we open them up slightly more, and then the blood flow can reach the fingers, the toes, and so on. Now, the side effects of alloprost, what happens is because you tend to do quite a lot of headaches and things like that, patient report, because we also opening up the blood flow to your brain. Yeah, so then that can create side effects in that aspect. And there are other side effects, but it's also particularly to the patients. Some patients experience worse side effects than others. So it's always with this medication, it's always better to review it at personal level and see what can be tailored for that patient specific.
Yeah, thank you for that. So Lisa was asking what should she do if her rheumatology department doesn't offer any ulcer care?
Yeah, this is one of the big things that I'm working on. So if it doesn't offer any ulcer care, see if other rheumatologists in the country. I know it's difficult because you might need to travel, but you might just maybe need to arrange for a few appointments at the beginning. So once you start being monitored and you have some advice, they can follow up with phone consultations. We do that with some patients that come from far. And then at least you are monitored, and then you get the basics of what to do, how to do. They can explain everything, and then you might be able to monitor them as more frequently at home, and then you come now and again on visits. So I would suggest You can. I'm happy to take, if you got the phone number, I'm happy to take the, you call me, I get the details, and I'm happy to arrange. So what we could do sometimes across trust is that you can do a joint care where your rheumatology refers you to us as a specialist center to Professor Delgado, and then we can take you into the clinic for the ulcer care. So there are ways around it because the service is not available anywhere else. We'll do. This is one of my aims for the research. So this research I'm saying, this project I'm doing right now, eventually the idea is that it will go multi-center and we will involve other centers in the UK. And with that, the idea is to start setting up other spokes around the country where they can provide ulcer care that is a specialist to scleroderma.
Oh, wow, that would be really great. Yeah.
Yeah.
So just a question about if fidicitin cream and using that with fabric plasters, is that one of the correct ways to take care of digital ulcers?
Sorry, I missed that one. Could you just say that again? Sorry.
About, forgive me if I'm pronouncing this wrong, fidicitin cream and fabric plasters, is that the correct way to take care of digital ulcers?
So fusidine is the antimicrobial. So the first question, the first thing I would say no. And the reason is for one thing, you need to use it. When we use antimicrobial treatment, it has to be when the ulcer has microbes on it. Let's say you have an infection with bacteria, then we're going to use antibiotics. So be it cream or oral antibiotic. Using the antibiotic constantly, what you're doing is that the microbes or the bacteria that is in that area becomes resistant to it. And then when you will need it, or when we need to act it through other antibiotics, it won't react to it because they become immune to it. So they basically are mutating into a form where you cannot kill them. So it's very important that the antibiotics, the oral antibiotics, the cream antibiotics, that they only use when there is an infection present. And the reason for this is because we also is a big movement about antibiotics stewardship. We are running out of antibiotics that are working, and we really need to make sure that we only use them when we really need it. So there are other ways of treating that microbes that are not needed to be treated with bacteria. With antibiotics. So those ones can be like silver dressings. Silver dressings will kill the bacteria if it's very localized. So there are other things that we will tell you when you come into clinic specific for your wound and how it behaves, and you can treat it. And then if we think you need to combine it, we will combine a dressing with a cream, or we will combine it with a dressing with an antibiotic, and so on. But the thing is, no, don't use it unless it's infected. And if so, ask your GP or go to a specialist to tell you.
Thank you for that. A question about what happens if medicine that you previously used does not work anymore. So Linda's asking about Bocetan and Iloprost used to work, but she currently has digital ulcers and they're not really working anymore. Is there a way forward from that? Different medication, I assume, type thing.
Right. So you just might find that it doesn't work as good as it used to work because maybe the disease has progressed. So the artery is a smaller or narrower because of all the pathology we were explaining before. That could be one of the reasons. So, and there could be other multiple reasons, but that could be one of them. Then the idea is if you're having ulcers, you probably should be on Bocentan. If you're having recurrent ulceration, you should be on Bocentan. That would be, unless you don't tolerate it or unless you have liver problems, because some patients, once they have liver problems, if liver function, it doesn't work, we can't give it. But it's one of the things that they have to try a combination of things. And also look at all these other things. Is the disease active? Okay, it might just be that you're having more ulcers because the disease is flaring as well, and you might have more inflammation around. Because I see one of the things with our patients that they tend to have what we call kind of more inflammatory related ulcers, where they are more inflamed, more angry, and it tends to come with the disease as well. The disease is flaring; those are also flaring. So because it's all interlinked. So there are multiple reasons why it might not be working and how it has to be looked, but also how are you emotionally? Are you very stressed? Are you carrying a lot of worries? Are you all of that will vasoconstrict your vessels, will just create more Raynaud's. The Raynaud's will worsen the ulcer. So it's just this really kind of do the self-check thing as well. Are you eating well? Oh, I know you have the problem with the guts as well sometimes, so that can also impair the absorption of the food. So maybe it has to be going to a dietitian, making sure that you have maybe supplements, so food supplements, so then we have the right vitamins to we can heal the ulcers. So it's all looking at the picture of the whole patient. So maybe move on to doses. Try other medication. I would suggest Bosentan, one of the important ones to see and discuss with your consultant. Check about are you well nourished? Are you good? Do you need more supplements for food and so on, vitamins, and make sure that also the levels of stress, anxiety, and so on are reduced.
Thank you. So Laura's asked about what is the best way to control the pain. Is there any useful tips for that?
Which pain?
The pain associated when you get digital ulcers and just dealing with them on a constant basis, that type of pain, I assume. But feel free to correct me if I'm wrong.
So the pain that is related to the ulcers. So you'll find at the beginning, when the period of time where it's ischemic, that the ulcer is occurring, that can be very painful time. And it's because the tissue is complaining constantly. Is I don't have enough blood flow, I don't have enough oxygen, I don't have enough nutrients, please do something about it. And that's why the pain is there. Pain is there to help us to do something about something that's happening to our body. The problem with pain is when it goes out of sync, when it just is not there just to tell us, and it's constant pain and it's really uncomfortable. That then becomes deteriorating to the person. So obviously, pain management is very important. The sooner you treat the pain management, the less problems you're going to have into developing chronic pain. So it's very important that the pain is targeted very early on. So discuss with your consultant the different type of pain medication they can give you. The problem, as it escalates the pain, you might end up having the drugs that they give you also impairs a little bit of cognitive function. It's like they give me more drowsy and so on, and it has other side effects that you might not be happy about. But as the ulcer progresses and it settles down and is healed, the pain should reduce. And if you're still having pain after the ulcer even has nearly gone, that is other pain. It could be pain related to the constant ischemic attacks or not having enough like Raynaud's attacks. Yeah, that can also create a lot of residual pain. There's very sensitive pain, and that might be nerve pain. So it has to be checked properly and see which pain you're targeting and target with the right medication. But also very important, pain happens in the brain. So the body has nerves, and those are the ones that tell us where it comes from, the severity of it, and what we need to do about it. But the pain happens in the brain. And once is the perception of other things, like how anxious you are, how you perceive pain, all these things is what makes the pain worse or makes the pain better. That's why pain is so subjective. Person might vary from one another, receiving the same stimulus or the same problem, it will vary between people because the pain is perceived on the brain. So very important that you can do to help yourself, maybe any meditations, any relaxation, things like that will always help, because you are triggering what is called the parasympathetic nervous system, instead of the one that is the system that makes us more nervous and more like fight or flight and more stressed. It's very important, all the calmness and the relaxation and so on. But also, this doesn't take away, if pain is present, it's telling you something is happening as well. So the first instant you have to go and have it checked. Don't ignore it and start meditating, because that's just a help. You need to do something about it. So go to your doctor and consultant and check that you are not going through an ischemic attack and that you really need medication immediately. So, but yeah, those are several things that you can do for pain.
No, that was really interesting. Thank you. I think we just have time for one, maybe two more questions. So is calcinosis always a separate entity, and so it can be dug out, or is it sometimes attached to the bone?
So calcinosis normally is not attached to the bone. It is within the tissue. So the way we see it clinically, sometimes you have it like eggshells within the tissue, right? Very thin layers within the tissue. And other times we have like little fragments or little pockets of like the pus type of thing, like a little bit liquidy and chalcoid that's coming out. Okay. And another times you have like little stones, like fragment of stones, like all around it, and plaques. It creates like plaques. The problem with that is because it's so much into the tissue. When they go with surgical incisions, it's really hard to take off because you're taking a large amount of tissue. So that's the problem we have with calcinosis. It was like a very localized piece. Sometimes superficially, we have a very localized piece that we can go with the blade and remove it, and then that's it. It settles down, and it never comes back. And sometimes it might come back later on within time. So those ones are very nicely targeted. You can remove it either that or with laser, but it's the one that is more within the tissue that creates more problem, and that they are plaques. And unfortunately, we do not have any medication that works fully. There are certain medications that seems to work a bit better for some patients than others, but there is still a lot of research that needs to be done for calcinosis, unfortunately.
Just one more quick question. Do you hear about people who go to warmer countries, and do you know if this helps?
Yeah, well, yeah, it helps in the aspect that because in warmer countries, you don't have the cold so much, so you don't have the Raynaud's vasospasms. It doesn't constrict as much. Mm. So in that aspect, yes, it does certainly help for the Raynaud's side of it. For the disease side of it in general, no, the disease probably will progress again. There is patients from Italy and patients from Spain, which is really nice and warm, and they still have the disease. They might just not experience this climate change like we do in here, so therefore might not have the Raynaud's as bad in that aspect, but they still have experienced the disease. So, and also the other thing is patients said, oh, I go to a warmer country and it gets much better, my ulcers. But you normally go to a warmer country as well on holiday, so you're also much more relaxed, and you don't worry about so many things maybe, and that can also contribute to help feeling that you don't have as much Raynaud's attacks.
That's a good point to make. Yes, so I think that's all we have time for today. So I just want to thank you, Dr. Begonya, and everyone for attending, and hope that you found it useful. I know I did. It was very, very informative. So thank you, everyone, for your time, and I hope to see you again next time.
Absolutely. Thank you very much to all, and thank you very much for listening and all these interesting questions, because I really love to hear all about it. Thank you.
Bye-bye.
Bye-bye, everyone.